new words. So lead 1 and AVL. It's lateral wall of the left ventricle. Lead 3 and AVF. It's inferior wall of the left ventricle. Inferior wall or diaphragmal wall. And then chest leads. V1 is septum, intraventricular septum. V2 is anteroseptal part. V3 is anterior wall of the left ventricle. V4 is apex. V5, V6, it's lateral wall of the left ventricle. When you put your electrodes on the back, you'll obtain V7, V8, V9, so additional back or additional dorsal leads. Yeah, so it's information from the posterior wall of the left ventricle.
We will get ECG or we have to do ECG?
Oh, you will have
You said you when you put it back.
it may be as a question. And you should understand why do you think so, why from this part, what did it say about? You can, if you want, you can photo all of them. Yeah, it's not a problem. It's not a close information.
We want what you explained.
Yeah. So when you obtain ECG, first of all you should determine the rhythm. So what kind of rhythms can be? So normally it's sinus rhythm. So the features of sinus rhythm is the presence of P wave before each QRS complex. Before each QRS complex. If P wave is connected with QRS complex, it's sinus rhythm. Sinus rhythm, yeah. Then lower. So the rhythm from the AV node. Absence of P wave. Complex QRS, they are narrow, and interval RR is equal. It says about the rhythm from the AV node. And ventricular rhythm. Absence of P wave and wide QRS complexes with the unnormal shape, with the so it may be splitted sometimes.
And F wave present.
No.
Abnormal shape of
It's F wave. It's not ventricular rhythm. I say about the pacemakers. So first and second and third grade pacemakers. And also you can obtain the ECGs with the combined arrhythmia, such as atrial fibrillation, atrial flutter. So now we will see the signs of atrial fibrillation. On the whole, atrial fibrillation, it's absence of the P wave before each complex. Also, not equal RR intervals. And third is small f wave. It's not obligatory sign, but absence of PP and as a rule not equal RR intervals is the obligatory. Atrial flutter. It differs from the atrial fibrillation with the amplitude of F wave. So in atrial flutter, F wave is high amplitude, but also QRS complexes are narrow. After you determine which rhythm, so you conclude. Rhythm is, for example, sinus or atrial fibrillation. So you say about the rhythm. Then you analyze ECG in all leads, comparing with the normal. So, and you should write, or maybe first write and then explain the pathologic changes which you find on the normal. So after you determine the rhythm, you should determine any arrhythmias and any conduction disturbances. as for rhythms, any type. So, I mean, first of all, it's maybe premature complexes, and you should determine the type of premature complexes, supraventricular or ventricular, and the frequency of these complexes, for example, bigamy or trigamy or anything else. Yeah. And as for conduction disturbances, it's atrioventricular conduction delay, and then interventricular conduction disturbances. As for atrioventricular conduction delay, it's blockades. Yeah? First, second, third AV degrees. And as for interventricular, it's his blockades of the bundle branch block of the left or on the right. Now we will see them. And then the changes. So you should pay attention to the pathologic Q waves. If you see, for example, it in the first lead, then you see on the AVL. So, and yes, it says about the probable history of MI. Also, ST elevation or ST depression. So ST deviation relatively to the isoelectric line. You first just describe what you see. Read, and then just description. So, Q wave in the leads 1 AVL, then Q wave in the lead V2, V3, V4, V5, V6. Also, for example, ST elevation in the leads V2, V3, somewhat V4, or V4, yes. And also negative T wave in the lead 1 AVL. The formation of T wave in the lead V3, V4, V5, V6. So you just write what you see. And then you conclude. So these changes are mostly characteristic for myocardial infarction of the, for example, septal, anteroseptal, anterior, and apical and lateral walls. In the subacute, you just list which places, and you then write the stage. So it says about the subacute stage, and it will be your conclusion. If you see, for example, as in this ECG, if you see only the rhythm strip, you, as a response, it will be there any rhythm disturbances or any conduction disturbances, and it will be the diagnosis. And it's not a diagnosis, it's not a clinical diagnosis, but it's your conclusion. So you should understand that you should not diagnose while ECG. You should give your conclusion. You should describe and give your conclusion as per this algorithm. What questions?
Doctor, can you please show us one by one, very fast, for example, like this
Okay.
page, and show what is the problem?
Okay. So it's the strip of rhythm. What is the kind of rhythm? P, 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 P. What is the kind of rhythm? Sinus rhythm. Okay. What problems can you see? Please look at them.
No problem with conduction. No complex they are.
It's normal. No. What is the second lead?
There is no leads. It's only a rhythm strip in the second standard lead.
Maybe too fast or too slow?
There's maybe like 3 squares, just sinus and tacking.
Also, colleagues, you maybe should know how to calculate the heart rate. RR interval.
Multiplied by the speed of the
speed
of the
Speed is indicated here, or 25, or it may be
0.5.
it may be 50.
And
So, but you should calculate the RR in seconds, and then you 60 divide on this RR. On the modern ECGs, it's written, it's typed. So, what problems in this ECG? Colleagues, you should not forget that if so you can see the ECG without any problems, and you should analyze, you should check everything, and you then say it's normal ECG. It's maybe potential, maybe, yeah.
this is ST like smile.
No, ST is normal. ST is normal.
AC is normal. QRS is narrow.
QRS is narrow, yeah. Do you know the normal ranges of the intervals?
Yeah, 0.12.
0.12.
So you should obtain, for example, PR interval, normal range from 0.12 to 0.2. It's normal. If it's less than 0.12, it's the pre-excitation syndrome or phenomenon. If it's longer than 0.2, it's delay of atrioventricular conduction, say about blockade. Also QRS complex. So normally it's up to 0.12. If it's longer than 0.12, it says about intraventricular conduction delay. So left or right bundle branch block. Also, ST elevation depression. So depression is ST depression is clinically significant as 1 millimeter in the chest leads and 0.5 millimeter in the extended leads. And as for ST elevation, it's clinically significant 1 millimeter in the standard leads and 2 millimeters in the chest leads, at least 2 chest leads. So as for this ECG, normal sinus rhythm, and I can't see any changes. But yeah, but on the whole, when you see the rhythm strip, you should seek any arrhythmia or conduction disturbances first. If you can't find, you can say that it's normal.
If a QRS is narrow, it's meaning you said.
QRS is narrow. It's normally
normal range.
هذا الكيس طبعا انا
Please, what can you say about this ECG?
Pathological
Rhythm, colleagues.
P waves is
Firstly,
absent.
rhythm. P wave is absent.
Yes.
RR are not equal.
Yes.
And here is the elements of F wave. Yeah. It's atrial fibrillation, and you can see also the premature ventricular complex. So it's wide, and it's not like other complexes. So you can say that atrial fibrillation with premature, also with premature ventricular complexes. Also this one. Also this one. Okay, is it clear? It's not like bigaminia, so bigaminia, each second complex is premature.
It's just premature.
Yes. You can say about multiple extrasystole, multiple premature complexes, but not bigaminia.